Hello student, as we have started GIT lecture in which we were discussing scenarios of the hepatobiliary system, in which we have discussed one scenario about the pancreas. Now today we are going to discuss two other scenarios of the pancreas. Moving towards our scenario, a 45-year-old lady came to the OPD with the cheap complaint of swelling in the epigastrium. Swelling in the epigastrium from the last 10 days. Her associated symptoms are early satiety, epigastric fullness, and obstructive jaundice. She had an attack of acute severe pancreatitis 6 weeks ago and treated conservatively. Now she is hemodynamically stable. In this scenario, the most important point is the acute severe pancreatitis attack. She had attack of pancreatitis 6 weeks ago, and after that she developed a mass in the epigastrium from the last 10 days, and the mass she has symptom of early satiety, epigastric fullness, and obstructive jaundice. So what are the possible diagnoses? For before going to the diagnosis, we have to look at another scenario on the same case. In the second scenario, there is a 10-year-old boy with upper abdominal or epigastric mass. Again, there is a history of epigastric mass, and he was treated 4 weeks back for acute pancreatic trauma. The patient has undergone a pancreatic trauma, either a blunt trauma or a penetrating trauma or an iatrogenic trauma, and after that trauma, he developed an abdominal swelling or epigastric swelling. The trauma can be after the Whipple operation, can be after the ERCP, it can be blunt or acute. Now, we know that after trauma, after acute pancreatitis, and after chronic pancreatitis, there is a condition which is called pseudo pancreatic cyst. This condition develop after trauma or pancreatitis, and in this condition, a swelling form, a cavity form in the pancreas, cavity form in the within the this is pancreas, and a cavity form within the pancreas having accumulate amylase protein in it, and cause a swelling in the epigastric region, and cause the pressurize the duodenum, so cause the obstruction of the duodenum, and due to gastric outflow obstruction, the patient will complaining of early satiety, as well as there is opening of the common bile duct in the duodenum. It can also pressurize the common bile duct and can lead the obstruction of the common bile duct and can cause obstructive jaundice. So that's why in the first history the patient was complaining of early satiety, obstructive jaundice, epigastric swelling after acute pancreatitis or after acute trauma. So the most likely diagnosis in this scenario is the pseudo pancreatic cyst. How you are going to investigate and treat this patient, and what complication this patient can develop? Moving towards our investigation, this patient, the diagnostic investigation in this patient are ultrasound and CT. Through an ultrasound, we can identify either the mass is cystic or the solid. If the mass is solid, then it will be the carcinoma head of the pancreas. But if it is cystic, then we can suspect a pseudo pancreatic cyst. From CT, we can also know about the cystic swelling. The pseudo pancreatic cyst is sometimes confused with the cystic malignancy of the pancreas. In the cystic malignancy of the pancreas, mucinous carcinoma of the pancreas is very common. To exclude this suspicion and to exclude the mucinous carcinoma of the pancreas, we do endoscopic ultrasound guided aspiration of the cyst. In the endoscopic ultrasound guided aspiration, we analyze the cystic fluid for the measurement of CEA and amylase. If the amylase level in the cystic fluid is high, if the amylase level is high, then it will be a pseudo pancreatic cyst. But if the amylase level is low and the CEA level is high, that is more than 400 milligram, then it will be mucinous neoplasm of the pancreas. The complication the patient can develop in the cyst are, in the cyst there are stages of the amylase, and collection of a fluid anywhere can lead to the separation of the fluid, and the patient can develop infection. As well as the cyst can rupture into the gut and cause melena. It can rupture into the peritoneum and cause peritonitis. In this diagram, this is the pseudopancreatic cyst. If it very large, if it is very distended and large, it can cause pressure on the duodenum, and when it exert pressure on the duodenum, this will cause the obstruction and the narrowing of the duodenum, due to which the when food come from the from the stomach to the duodenum, there will be obstruction to the outflow tract of the food, and the patient will feel early satiety. As well as this cyst can pressurize, this is the common bile duct, this is the CBD. This cyst, if very large, it can exert pressure on this common bile duct and cause obstruction of the bile duct, due to which bilirubin and bile will get accumulate in the biliary tree and will lead to obstructive jaundice. This in this cyst, as there are fluid accumulated which is amylase, and due to the stresses of the fluid, infection can occur here and can lead to infection. In this cyst, if this cyst rupture into the peritoneum, it can cause peritonitis. This cyst can also rupture into the gut, that is into the duodenum or into the small intestine, and can lead to melena. Now, how can we manage this patient? If the cyst is less than 6 centimeter, then it usually resolves spontaneously. But if it is more than 6 centimeter, and if it persists for more than 12 hours, then in this case we will do some therapeutic intervention. In the intervention, we can do the intervention the cyst can in the intervention the cyst can be drained either endoscopically or by open surgery. In endoscopy, we do cystogastrostomy and cystoduodenostomy. In cystogastrostomy, we place a stent between the cyst and the stomach. If this is a pancreas and there is a cyst and above there is stomach, we place a stent between the cyst and the stomach, and this stent will drain the fluid of the cyst into the stomach. We can also place a stent between the duodenum and the cyst. This is the cyst, and we can place a stent in between the duodenum and the cyst. This will drain the fluid of the cyst into the duodenum. This is called cystoduodenostomy, and when the fluid is drained from the cyst to the stomach, then it is called cystogastrostomy. We can also do percutaneous transgastric drainage, that is, an incision is given through the skin, and then drainage of the cyst occur, which is called percutaneous aspiration. In open surgery, we can do cystogastrostomy and cystogegenostomy. In cystogastrostomy, we open the anterior wall of the stomach and hold the anterior wall of the stomach by Babcock forceps. Then we create an anastomosis between the posterior wall of the stomach and the cyst. And in this way, the cyst drain into through the posterior wall of the stomach into the stomach, and we then close the anterior wall of the stomach. The anterior wall is actually open, and then we reach the posterior wall of the stomach. A hole is created in the posterior wall of the stomach, and this hole is connected with this cyst, and through this hole the cyst drain into the stomach. This is called open cystogastrostomy. And in open cystogegnostomy we also make a hole between the duodenum and the cyst, and in this way the cyst drain. Suppose this is the duodenum, the part of the small intestine. We make a hole in the jejunum and the cyst drain into the jejunum. This is called cystogegnostomy. Thank you. This is the end of this lecture. If you like my video, please subscribe my channel and share the videos. This will increase my motivation for making more and more scenarios.